All right, good morning, everyone. Dr. Randall Gates, board-certified chiropractic neurologist, also a chiropractic physician at Gateswood Health. This morning, we're talking about Parkinson's disease, and I'm joined by my dear friend, Kathy. Kathy, you're there, correct?
Yes, I am.
Okay, so Kathy, you brought this topic up because you know people with Parkinson's, and you thought it'd be a good thing for us to discuss. You've seen me work with Parkinson's patients. So why don't you kind of guide me to the promised land, so to speak?
Okay, well, I think the first place to start is just to give everybody an idea of what is going on in the brain of a Parkinson's patient. I mean, with that, there are different brain maladies that are out there. What goes on with Parkinson's?
Parkinson's is a neurodegenerative disorder, and in essence, they're losing their ability to produce dopamine. That's what's going on. There's the accumulation of abnormal proteins, most typically in the dopaminergic parts of the brain. And when that happens, then slowly, dopamine loss keeps occurring. If it reaches a critical point of no return, so to speak, then that's where the Parkinsonian symptoms start to develop. But like we were discussing earlier today, that there can be other signs years before the Parkinson's develops. So we're going to go into that a little bit. So if you or a loved one know someone who's having those symptoms, then maybe you can get them to a doctor sooner.
And does that loss of dopamine, I mean, I'm assuming like everything else that we deal with, that varies from patient to patient. Some will be much more rapid and some much more gradual.
It does vary. That's a good point. It does vary patient to patient. There are differing degrees of it, and it's hard to explain why some patients have such a precipitous decline while others maybe it's more slow. Also, there are different manifestations of Parkinson's disease. So some patients have a very prominent tremor, whereas other patients have almost minimal tremor to no tremor, but they're just frozen and they have a really hard time moving. So yeah, it can manifest in different phenotypes, as it's referred to.
Okay. So what are some of the early symptoms that someone might notice in a friend or family member?
Ironically, it's constipation. Now, a lot of our patients have constipation. Yeah, so don't worry, everybody. I'm not trying to freak everybody out that you have Parkinson's.
We all have Parkinson's.
So if you've gone from having normal bowel movements to the slow decline of, slow transition into constipation, it may be something to be attentive to. Now, that's the first symptom most commonly. The reason why it's called the Brock's staging criteria. So there's this guy named Dr. Brock, and he had this staging criteria for how Parkinson's actually develops. And what happens is that the abnormal accumulation of proteins in nerve cells actually starts in the gastrointestinal tract, within the different plexuses of our GI tract that allow for motility. So it actually starts there. That's where they're seeing it. They also see it starting in the brainstem, and it works its way up into what's referred to as the midbrain, which is the substantia nigra pars compacta, which is the dense part of the dopamine producing part of the brain and the front part of your midbrain. Lots of verbiage, just basically where dopamine is produced, and finally these abnormal proteins accumulate and then start sacrificing dopamine production. And good morning to everybody who's joining. Just wanted to say that. We have a lot of people saying hi to us, Kathy. So.
Okay, well, hi everybody. And again, this takes us back to like we always do, and that is the gut controls the brain and the brain controls the gut. So again, we still have that connection, even in Parkinson's. So, I mean, this is stuff I don't think people ever realize, that things like that, it's almost thought of as, to me, I see it as almost a behind-the-scenes sneaky kind of thing going on. Okay, I think my brain's okay, but here my gut's messing me up. So,
right.
And it's just another one of those things that that I think a lot of other physicians aren't aware of or haven't studied. So I'm always thrilled to hear these things that you come up with that I've not heard anybody else talk about. So,
thank you.
And when you look at those things, we start with the constipation, and what do you think you're going to see next? Maybe
lots of times you see shoulder pain. Shoulder pain is one of the cardinal symptoms as well. The reason why is that there's this rigidity that's happening in the body of a Parkinson's patient as they lose dopamine, and so they tend to get a stiffness in the shoulder. And so one of the physical exam findings is for the doctor to move limbs around, and you kind of feel for the fluidity of it. Parkinson's patients will be really rigid, or we call it cogwheel rigidity. So it's going to feel like this when the doctor passively moves their arm. Well, that's going on all the time in their body. So they're going to reach for a cup of coffee, and they have that rigidity to it, which then tightens the muscles and causes the shoulder to move abnormally, and typically manifests as the shoulder pain. So that's something that a lot of musculoskeletal doctors have to be aware of, chiropractors, physical therapists, because they see people for shoulder pain. And it's important in the assessment to look at the overall picture of that human being and say, well, is this just a rotator cuff problem, or is there something neurological going on? And that's what doctors of chiropractic and doctors of physical therapy are trained to look for.
But a lot of times, are they not going to go ahead and do MRIs and that sort of stuff before they ever think to look in the Parkinson's direction?
I mean, that's one argument. And the MRIs at this point are pricey. And I was just talking to a friend who's a neurologist about these MRIs. They're called DAT scans. So everybody should be aware of these. You know, we all love imaging, and there is this new type of SPECT scan where we can look, relatively new, where we can look at how much dopamine basically is being produced in different parts of the brain, how it's being received, and that can add to the diagnosis of Parkinson's disease. So yes, somebody could refer them for that, but Parkinson's really is generally accepted as a clinical diagnosis. And that's where lots of times when I'm talking about fibromyalgia, I'll say fibromyalgia is a clinical diagnosis. And so many people bag on fibromyalgia because there's not one lab test and there's not one finding. Well, there isn't with Parkinson's either. Basically, Parkinson's is a conglomeration of someone who's having rigidity. They may have tremor. They're having slowing of movement. So you have them open and close their hand 10 times. And, you know, it's like, or you're talking to them and they just stare at you. And so that's called hypomimia. All those different findings. It used to be that postural disturbances were characterized into Parkinson's. Some criteria say now no. Anyways, that's basically how a doctor diagnoses you with Parkinson's. So, and know that, again, you don't have to have tremor to have Parkinson's.
Okay. And we're all familiar with Michael J. Fox. We've watched him on TV. He's kind of the poster child, if we want to use that term, for Parkinson's, because for someone as young as he was, to be diagnosed with that. And if I had watched some old Spin Cities lately, and my husband's like, nobody diagnosed him back then. He's all over the place. I'm like, yes, the movement's there, but he was always a very animated actor, even in his 80s sitcom or whatever. So it's like, maybe that doesn't come into play. Maybe he noticed it, but maybe he didn't send out to anyone else.
I don't know. Yeah, I can't speak to his medical record, but I thought I saw that there was some awareness of it back then. And lots of times those flailing movements are dyskinesias, and those dyskinesias can be associated with the medications for Parkinson's. And they are one of the side effects that doctors have to be aware of, those kind of what you're referring to, Kathy, and I don't know how to characterize it in an elegant way, but basically, some of these movements are kind of moving the head around. It's not Parkinson's. Those are referred to as the drug-induced dyskinesias. And it's a balance, because with Parkinson's, doctors are trying to elevate dopamine levels, but sometimes you can kind of go a little too far. If you go too far, you can get dyskinesias, or you can actually develop some psychiatric symptoms as well. And there's a great book. It's called Movement Disorders, 100 Destructive Cases. I believe that's the title. And in essence, they go through case after case of this neurologist experience where they're doing the right thing, giving the people the medications. But, next thing you know, grandpa is seeing elephants in the room, and, he has his underwear off and running around. And it's and while that may seem funny, it's extremely disconcerting. It's extremely painful for the families who have to see these things go on. So that's kind of the reality of Parkinson's from that standpoint.
Okay. Well, and that's why I brought it up to you yesterday or whatever, with this commercial talking about this medication that they should take, but they didn't make it sound like the medications would cause the hallucinations, that they needed the medication because Parkinson's patients have hallucinations and whatever. And I'd never really heard that before, and I found it kind of odd and wondered what could be going on in the brain that would actually cause a normal, even in this case, say someone who looks fairly healthy, whatever, they're in pretty good shape, why all of a sudden they would be having hallucinations. But it sounds more like you're saying it's the drugs that are administered that cause this sort of reaction.
Yes, the detailed nuances of dopamine metabolism in the brain are pretty complicated. There's a lot of receptors. There's a lot of different, areas that it is produced. But simply, there are two. All of you have heard me talk about like COMT and its effects on anxiety. So, for example, just a little tangent. If you have too little dopamine, there's a tendency, particularly for a guy, to be flat. So just kind of unexcitable. These are the people who need to be they need the motivational instructions to get going, to get to the top of the curve where they're productive. There are other people who have way too much dopamine at a resting level, and they tend to be more anxious, and their mind works really fast, and they tend to be a little sharper, but they have a propensity to be pushed way too far out if they come under stressful circumstances into more anxiety. Now, with Parkinson's, I'm not talking about COMT, but I'm talking about different ends of the spectrum. If you have too much dopamine, then that is commonly associated with psychiatric disorders and psychiatric conditions. So the hallmark one is schizophrenia, where they tend to have way too much dopamine produced from an area called the nucleus accumbens. And as a result, then they will develop things like hallucinations. Now, doctors will give them medications, which are referred to as basically the antipsychotics, and they're different. There's atypical and typical antipsychotics, and they give them these medications to bring their dopamine levels down so they can be more normal. Now, when they do that, there's actually something called drug-induced Parkinson's, which is where when they give them these meds, these antipsychotics to bring them down, they can actually develop Parkinson's disease or a Parkinson's-like picture, where they're very slow, they may develop a tremor, they're rigid. And so that in of itself started illuminating to doctors when they started using those classes of meds, what's actually going on in the brain with dopamine metabolism. Flip side, you take someone with Parkinson's, they don't have any dopamine, you start throwing them on a bunch of dopamine-based medications to try and get them to move, to try and get them through their daily routine. And then you can push them a little too far, and then they start having hallucinations or odd behaviors or inappropriate behaviors. And certainly that doesn't apply to everyone with Parkinson's, but it is an issue that neurologists have to be aware of when they're titrating these medications up and down. It's not so easy. So yeah, that's kind of the answer to that.
Okay, that's what I find so interesting about the brain and everything that you know about it.
Mm-hmm.
We all grew up. When I'm a little kid, you used to take your finger and twirl it beside your head and point to somebody like they're a little crazy.
Mm-hmm.
And for years, people have talked about chemical imbalance, and I think this is one of the places. And I know it's a totally separate thing about what we're talking about on Parkinson's, but I think it's so important for people to realize that so much of what we talk about as being psychiatric problems that people are taught to think of as a terrible thing is just that, a chemical imbalance that just needs to be adjusted in so many people and can be from so many different things that to me is extremely interesting, but also the fact that you and some other people understand that this thing of the stigma that goes along with psychiatric issues really, really, really can be cleared up, and people can understand this is not a weakness in you, this is not a defect in you, it just happens to be the way your body's operating. Somebody else's is doing something else weird, but yours is doing this. None of us are perfect. It's like having an engine that's only, if you got an 8-cylinder and you're only hitting on 6, then you adjust that. So I think it's really important that people pay attention to those sort of things, because it's easy to sit at home and, whether they're depressed or feel bad or whatever, realize that there's a physical reason 90% of the time for this sort of stuff, and that they don't need to feel bad about that. They just need to make sure they get the help they need and fix whatever that chemical imbalance is. I just find, when you talk about the brain, I just find it fascinating, all the different nuances that are involved in what people need to understand, and the gut the same way. Those two things, one's like the battery for the car and the other one's the engine.
That's a good analogy.
Without one, you're not going to do anything.
Well, that's perfect right there. And you're right. And basically, the more we understand about the brain, the more understanding we can have for everyone around us, our loved ones, and people we interact with. Lots of times we are all ruffled when we, interact with somebody who may be difficult to talk to, or we have a loved one who's suffering with a mental illness. And we have to understand that we are our neurological function. We are our nervous system. And that plays into our immune system heavily as well. And now I can't say this for Parkinson's, but most of the conditions that Kathy was mentioning, things like depression, things like bipolar, things like schizophrenia, have huge associations to the immune system. If anything, something like schizophrenia is basically an autoimmune illness affecting the brain. But not many people know that. And that's why we're trying to get some of this information out there. Yesterday, I was printing out articles for someone talking about gluten sensitivities and psychosis. If a mom, they did a study, I think it was in Sweden or Denmark, if a mom has gluten antibodies, she can pass those antibodies to her offspring, which predicts that they're more likely to have a psychotic episode later in life. Like, holy moly. But we've known this for a while, but a lot of people don't know this. And like bipolar has this huge associations with gluten sensitivities, inflammation in the brain, all these different variables. So yeah, to kind of capitalize on what Kathy said, it is very interesting. We need more empathy for those around us. And Kathy and I have talked about the genetic component too. Some people just genetically don't produce the right neurotransmitters. They don't break down inflammatory molecules in the brain. That segue leads into Parkinson's because there can be a genetic proclivity to not break down this thing called alpha-synuclein. So it's referred to as an alpha-synucleinopathy, which interferes with how basically dopamine is produced and released through vesicles. So yeah, and then going farther with Parkinson's, there is a whole gut connection. And what researchers think is that when you develop basically the Parkinson's process in the gut, and the gut gets turned off and we lose motility, you develop what's referred to as small intestinal bacterial overgrowth. We get this overgrowth of bacteria, and then these bacteria then release pieces of bacteria into circulation, which is highly inflammatory. And it's thought that maybe that then contributes to the the neurodegenerative aspect of Parkinson's. I haven't had my morning coffee. But yeah,
work sometimes. See, you're not firing on all eight.
I'm not firing on all 8 cylinders. No, late flight last night, snowing in Reno, but we're here. So, but yeah, so that can contribute to the neurodegenerative aspect of Parkinson's.
Yeah. So, what can be done? I mean, what can be done naturally for these folks? Is there something? I mean, how important is it we catch it early?
In my experience, it's all about what that individual wants. And we do have some patients, Kathy, who have what are referred to as Parkinsonism diagnoses as well, who are probably watching. And Parkinsonism disorders are more based in balance. They're more based in lack of movement. They're more based in falls. They're more based in more symptoms like urinary urgency and low blood pressure and things of that nature. I say this because those conditions, in my experience, as well as the postural component of Parkinson's, seem to be what works best for our types of modalities, i.e., if you're a Parkinson's patient and you're having trouble walking, if you're a Parkinson's patient and you're having trouble moving, it seems like that's where I've had the most success in helping people. Keep in mind, though, this is still a neurodegenerative disease. That's our understanding at this point. And there's nothing to my knowledge that really completely reverses Parkinson's. So having a solid understanding of what the lay of the land is, so to speak, because lots of times people come into alternative offices and they're expecting to be cured. We don't know if, I'm sorry to say it this way, we don't know of any cures, but have I been able to see patients where it seems like the progression slowed, or where we were able to get them a lot more function for a lot more years and better quality of life, which was significant, where they're able to move and not fall over when walking? Yes, I've seen all that. So that's kind of my take on it, because we do have other examples of autoimmune disorders we work with where people have seemingly like miraculous recoveries. So that's my take. And as you know, Kathy, you've seen me work with people who are, in wheelchairs and then they weren't in a wheelchair anymore. They were up and walking.
Yeah,
and that was because we
happy
helped
and
them.
Smiling, and they think you're a god because they're not in the wheelchair anymore. And it is, like you said, it's not a black and white. Okay, I'm dealing with this today, and tomorrow I'm cured. But the fact that they can walk again, they've got balance, and even I've talked about my mother-in-law before, and she did have a dementia issue. The neurologist that she saw for that after, I don't know, she kept falling and having issues.
Right,
And then that neurologist looked at me and she said, this could be Parkinson's. And, look at how she walks, look at this, look at that. And again, I took her to you and you checked out, they were talking rigidity and stuff, but that rigidity that they were viewing, you did your little thing and checked her out and said, no, that's not what we're seeing here. That's just her being anxious or whatever, stiffening up and not relaxing just because this whole thing, gets under her skin. So she tightens everything up.
Right.
And I think, I don't know, the regular medical model just seems so quick to jump to these certain, to these things. And they do it, I guess what upset me, and I think other people would feel the same way, when you're sitting in an office and you have an elderly relative and you're asking for diagnoses or you're asking for some sort of answers as to what's going on with this person. And they so matter-of-factly start throwing things out there like this patient can't hear, and it's not, like it's not going to scare them to death or put them in another bad place because somebody's kicking around things that they've heard of all their life as really bad stuff, but they really don't have any findings to support it. They're just, second guessing and trying to come up with some things. And I'm sorry, but I know you talk about a doctor bedside manner, whatever you want to call it. When you have, especially an elderly person who has some dementia or something, all you have to do is throw one of those things out there. When they go home, they're sure they have it.
Right.
Right. And for them, it's another, okay, I might as well just go ahead and cash it in because I've got this. They said I had that.
Yeah.
I think it's important that empathy be related to that, doctor, and that's what I've always seen with you is that, I mean, you take it very seriously what you're telling these folks, and whether they can look for improvement or, okay, there's been too much degeneration, there's really not much we can do. But again, I think it's a big thing to look for those symptoms so they can be looking at that, or if they're seeing something or they're not feeling right, something's doing something here that I never used to happen. Maybe it's, they need to have that looked at and try to figure out what that is before there is too much degeneration, I guess. And we say that about Alzheimer's and dementia as well.
Right. And the two can overlap. So there is something, looks like our connection got paused. That's weird. Anyways, there is something, where was I going with that? Basically, there's overlap between dementia and Parkinson's. And so, Facebook Live just stopped. So in essence, Parkinson's can lead into dementia, and dementia sometimes can start as a Lewy body dementia, which then leads into Parkinson's. So it looks like we lost the Facebook, Kathy. So maybe we just wrap it up there. I think we hit the nuts and bolts.
Okay.
And
I didn't mean to go off on such a
No, you're good. You're good. You're good. I've never had this happen before, so I have no idea what just occurred. Maybe it's with the snow. We just lost internet or something.
Okay, so I assume sometime today you can get on there.